My name is Abdul Rahman Ahmed. I'm one of the Advanced Cardiac Imaging Fellows at the Cleveland Clinic main campus. I'm going to switch gears and talk about a tricuspid valve, the forgotten valve, and hopefully highlighting one of the mechanisms of important tricuspid regurgitation mechanisms, and specifically in the subset of patients who have tricuspid valve and ring. So our patient today is a 79-year-old woman who was being referred to us at Cleveland Clinic for a second opinion regarding a persistent severe tricuspid regurgitation. She had multiple interventions in her tricuspid valve. About 3 years before coming to our institution, she had a surgical mitral and tricuspid valve repair. She had a contour 3D annuloplasty ring in the tricuspid valve position. After that surgery, the mitral valve repair was successful, but she continued to have moderate to severe tricuspid regurgitation. And so about a year later, she undergoes a percutaneous tricuspid valve and ring with a Sapien, Edwards Sapien 3, 29 millimeters. And at the end of that procedure, she was noted to have a paravalvular leak. So she also underwent, during the same procedure, plugging of the PVL. So basically, after that, she still has a significant TR on her echoes. So we get this patient in our institution who has an annuloplasty ring in the tricuspid position, has a Sapien valve, and a PVL. But with all of that, she still has persistent TR. So I'm going to show the role of multimodality imaging and kind of how we evaluated this patient. So there's a bunch of images. Feel free, anyone from the audience or from the panel, if they want to make any comments or ask any questions or go back to some of the previous images, we're happy to do that. So obviously surface echo, RV-focused view, just to kind of get the anatomy. You can obviously see the struts and the metal frame of the valve kind of into right ventricle, and you can also appreciate some of the leaflet motion over here. We'll do some color compare. I think one of when the patient was referred to our institution, the concern was that was there a PVL that is persistent, and I think one of the things that I'll highlight in this image is that there isn't really minimal, if any, the regurgitation through the valve. And you can see that on the septal side, there's a little bit of regurgitant jet that we can see there. This is another image. I think this is really nice because it's showing you the PISA here on the septal side of the valve. Again, showing that there's nothing transvalvular. There's a concern for a PVL, but I would highlight that at this point from these images, there's also concern that there might be a regurgitation going through the open cells of the tricuspid valve, and I'll try to show this in a minute. So at this point, we do have a concern that there might be some regurgitation mechanism, not really transvalvular, not really paravalvular, but maybe going through the open cells of the frame. The TE was a little bit challenging images, but again, you see a little bit of an eccentric jet. On the left, this is an en face view of the tricuspid valve, and again, not very clear yet. This is just an X-ray. I thought it was interesting just to kind of get the anatomy and the relationship of all of these devices next to each other. This is a mitral valve repair. If you focus here, you can actually see the tricuspid valve ring. You can actually see the relationship between the ring and the valve, and maybe they're not very well opposed to each other. I will also point out, because we said the patient had a had a plug, so what is the plug doing what it's supposed to do? And you can actually see the plug in this area. I'll actually show a better image. This is from the fluoroscopy later down the line. And the thing to point out is that the plug is actually placed in a way through the frame of the valve. So it's not really doing what it's supposed to do, and it's really positioned in a wrong way. Obviously, it should be kind of in this way, kind of closing the gap. So clearly through the frame of the valve. So CT imaging was very helpful in this case, as it always is in tricuspid valve cases. In general, we're kind of doing a spin around the tricuspid valve here, just to kind of appreciate the 3D anatomy of the tricuspid valve annulus. It's not really captured in one plane; it's seen in multiple planes. And if you look here in a minute, you will appreciate also the plug kind of going into the frame of the valve. And I think I have a better image coming up. So this image is very helpful. So we have the coronary sinus here, right atrium, right ventricle, and you can see that the frames, the cells of the frame, part of the cells are in the right atrium, part of it in the right ventricle. There's a little bit of a gap here. And so you can imagine or visualize that there could be some way for the blood to regurgitate through these cells into the right atrium. And basically, to kind of explain this better, basically with systole, you can see the blood kind of goes through these open cells into the right atrium. Okay. Any comments from the panel or anyone from the audience? Okay. All right. So at this point,
we need to.
Yeah, we're almost concluding here. So at this point, our diagnosis is that this valve placed in the ring, and the regurgitation is not paravalvular. It's not through the leaflets. It's actually through the open cells of the valve. And just to understand why could this happen, the CT scan is taken before the patient received the transcatheter valve. And you can see that the annuloplasty ring is really kind of pulled away from where the septum is. And we understand that the valve is going to be placed wherever the annuloplasty ring is, and you can predict potentially that the valve might have a gap in the septal area closer to the coronary sinus where, in this patient, where the regurgitation was. I'm going to move on. And then this is just to kind of see that the blood basically, this is from the aortic position, but the blood basically is seeping through these open cells. Let's go one slide back, Mike. Thanks. At this point, I don't know if anyone has any thoughts about what would be the best way to solve this problem.
Yeah, well, we can talk about. I mean, we're a little bit pressed with time, so I think
this is the last few slides.
Yeah, you have a problem there with the skirt. So the skirt is not sealing the ostium. So I mean, you already gave that away.
Yeah,
but,
exactly.
It's complicated. So what you can do is put another valve to extend that skirt, and then seal the ostium.
Yes.
You need to understand the images and interpret the mechanism very well before you make a decision there, because the instinct is it's perivalvular. You would try to think that maybe you can close something, but you really need to understand the mechanism in order to provide a meaningful solution in this case like you did.
Yeah, thanks, Dr. Cohen. Yeah, that's exactly what we did. We put a valve in valve, and the idea is that the new valve will just push the leaflets of the previous valve and close this opening. And this is the initial result. We had a PVL at the area where that misplaced plug was, but then with dilation, we were able to achieve this final result.
The new Recilia valve also has a longer skirt. The new 29 Recilia valve has a skirt that covers almost the entire stent. So, and the M3 also has a stent that covers the entire valve. So that could have been handy. But no, this is nice because you split the leaflets open.
Yeah.
Okay.
Thank you so much. So just take-home points is the transcatheter valve in valve ring. You can have this regurgitation through the open cells of the frame, and that this can be predicted with multimodality imaging. And plugging is not going to work in these patients.
Thank you.
Thank you so much.